Welcome to the deep dive. We take a whole stack of sources, research all that good stuff, and boil it down to what really matters.
Yeah,
Just for you.
exactly.
And today, think of this as a really focused study guide for your end-of-course review.
Mm-hmm.
We're not aiming for you to just memorize a bunch of isolated facts. It's about, really getting the core ideas behind a whole range of critical mental health and substance use situations.
That's the goal. We want you to connect the dots, to think critically about these scenarios, not just recall information parrot fashion.
Right, so you can actually analyze what's happening.
Exactly. It's about building that deep understanding, that ability to see the connections and apply the knowledge effectively, not just ticking boxes.
And we have got quite a bit to get through today. We're going to touch on substance use and addiction, neurocognitive stuff, the aging process.
Mood and anxiety challenges, definitely.
Yeah, and then personality disorders, trauma-informed care. It's pretty comprehensive.
It is. It's designed to really solidify your understanding across these key areas.
Okay, let's dive in. Let's unpack this. So kicking off with substance use, how things present themselves. A really key idea here, I think, is recognizing the opposite effects. Intoxication versus withdrawal.
That's fundamental. It really is. Take stimulants, for instance. When someone's intoxicated,
Yeah.
well, it's like the brain's accelerator is jammed down.
It's throttled.
Yeah, that big surge of dopamine, norepinephrine. It's not just abstract chemistry. It actually explains why they're agitated, maybe intensely nervous, even paranoid sometimes, really distrustful. You'll often see enlarged pupils, that racing heart, tachycardia, and long-term. Chronic users can end up quite underweight.
So intoxication is the accelerator, then stimulant withdrawal.
Yeah.
And that's got to be the big crash, right?
Oh, absolutely. The ultimate crash. We're talking profound fatigue, serious depression, sometimes even with suicidal thoughts, sadly.
Wow.
Lots of sleepiness, excessive sleepiness. And then later, often an increased appetite. So knowing those opposites, that push and pull, it helps you see the whole picture.
Makes sense. And what about the longer-term effects? Say, chronic alcohol abuse.
Right, the chronic impact. Key assessment findings there paint a really concerning picture of, well, systemic damage.
Like what specifically?
Like severely anemic hemoglobin levels, maybe down at 6 GMDL, which is really low, severely limiting oxygen getting around the body.
Huge impact.
Huge. And you'd likely see impaired coordination and balance, too. That's ataxia. Diminished deep tendon reflexes. And a significantly low white blood cell count, leukopenia, maybe around 1,000 per microliter.
That leukopenia, that sounds like a massive red flag for just general health. Makes them vulnerable to everything, right?
Absolutely vulnerable to almost any infection. And stepping back a bit, thinking about the broader picture, let's talk adolescent substance abuse.
Okay.
It's interesting because even though overall substance use trends might be declining in some areas, alcohol, it still seems to be the most frequently abused substance among adolescents.
Still number one, despite everything.
Yeah. And the critical thinking point here is why? Why does alcohol hang on to that top spot compared to, say, illicit drugs or even prescription opioids? What does that tell us about our prevention strategies? Are they working? Do we need to adapt them?
That's a really important question for public health. And speaking of prevention, what about the red flags for unsafe opioid use? What should we be looking for?
Good question. You're looking for behaviors like doctor shopping, going to multiple doctors to get prescriptions, or just taking more of the opioid than was actually prescribed. Accessing them from non-healthcare sources is another big one. Friends, family, off the street.
Risky.
Very. And what's really worrying is sometimes you see this decreasing perceived risk among users. They start to underestimate the actual danger of overdose, which is tragically high.
So what makes someone more vulnerable? What are the main risk factors for addiction itself?
It's usually a mix of things, rarely just one factor. Environmental influences are definitely big peer pressure, how easy it is to get substances, chronic stress, maybe a history of trauma. Then, co-occurring mental health disorders are often intertwined. People might self-medicate, to cope with anxiety or depression.
Makes sense.
And, of course, there's often a strong genetic predisposition. A family history really increases susceptibility. But something like, say, doing poorly in school, that's usually a consequence or something happening alongside, not really a direct cause or predisposer of addiction itself.
So it's complex, multiple pathways.
Exactly. And understanding those different pathways is crucial if you want a truly holistic approach to prevention and treatment.
Okay, so let's picture someone presenting right now with acute opiate intoxication. Maybe they've used intravenously. What are the classic signs?
You're going to see significant central nervous system depression. Think drowsiness, that classic nodding out appearance.
Yeah.
Pupils will be constricted pinpoint pupils, miosis, and slurred speech. It's a real heavy sedation picture.
And then, predictably, the opioid withdrawal is the opposite.
Totally the opposite. You get this whole constellation of, well, flu-like symptoms, basically. Nausea, vomiting, sweating diaphoresis, lots of yawning, muscle aches.
Miserable.
Oh, completely miserable. Tearing eyes, runny nose, their pupils will dilate now, goosebumps, piloerection, and diarrhea. But here's a really important distinction.
What's that?
Unlike withdrawal from things like alcohol or benzodiazepines, severe complications like grand mal seizures, they are not typical for opioid withdrawal. That's a key difference to remember.
It's a crucial point. Now, thinking about the recovery journey, the SAMHS recovery model for substance use disorder, what's the core idea there?
It's a really powerful person-centered approach. The core principle is collaborating with the client,
Right?
identifying their personal strengths, finding community resources that can support their specific recovery path. It shifts the focus away from deficits and problems.
Towards strengths.
Exactly, towards their inherent capacities.
Right.
It emphasizes hope, empowerment, self-direction, and importantly, it recognizes relapse not as a failure, but as potentially part of the journey.
That feels like a much more humane approach than some older models.
It really is. It contrasts sharply with those more traditional deficit-focused ways of thinking.
Yeah.
It's about building with the person, not just trying to fix them.
Makes sense. And just a practical point for people working in care settings, drug diversion, what are the signs?
Yeah, vigilance is key there. You need to look for patterns, frequent discrepancies in opioid counts when medications are checked,
Okay.
unusual amounts of opioid wastage being recorded, or lots of corrections being made to medication administration records. Those kinds of patterns can signal a serious problem that affects patient safety and, frankly, the integrity of the medication supply.
Got it. Okay, let's shift gears. Moving away from substances now, let's talk about cognitive changes, especially if people get older. Some really important distinctions here.
Absolutely. And probably one of the most common challenges is telling the difference between delirium and dementia.
Right. How do you do that?
The absolute hallmark of delirium is its acute onset. Confusion develops quickly over hours or maybe days.
Okay, rapid.
Very rapid, which is a stark contrast to Alzheimer's disease, which typically develops gradually. We're talking months, even years. So if someone becomes confused very suddenly, like within a week, that should immediately make you question an Alzheimer's diagnosis and look for other causes.
What kinds of things might cause delirium then?
Lots of things. Polypharmacy, being on multiple medications, is a big risk factor. Decreased social interaction can contribute too.
And protective factors.
The flip side, really, increased social interaction, regular physical exercise, consistent sleep patterns, those seem to be protective. When you're assessing someone, you really need to know the exact onset date of the symptoms, any recent medication changes, especially things like anticholinergics or sedatives, and any new physical signs like muscle weakness.
And the symptoms of delirium itself.
Usually it's a new onset disorientation, trouble concentrating, maybe new agitation, and sometimes, if it's a recent onset, visual hallucinations can occur.
So for someone in late-stage dementia, the focus must shift quite dramatically.
Completely. The priority becomes ensuring their comfort and safety above all else. Creating a safe environment, making sure pain is managed effectively, meeting all their basic needs, hydration, nutrition, hygiene, and providing really comprehensive palliative care. It's about quality of life at that stage.
And for Alzheimer's safety interventions earlier on, what kind of things help?
Environmental modifications are key, supervision too. So removing potential hazards from the home, installing safety locks on doors, maybe using bed alarms if wandering is an issue. Ensuring good lighting, maintaining consistent daily routines, those things really help reduce confusion and risk.
And even basic things in an inpatient setting, like footwear.
Absolutely. A primary intervention for anyone with a neurocognitive disorder in hospital is patient safety. And that includes simple but vital things like making sure they have well-fitting, non-slip footwear to prevent falls.
Makes sense. And what about pain management in the elderly, especially using narcotic analgesics? What are the risks?
There are definitely increased risks you have to weigh carefully. Increased risk of falls is a big one. Respiratory depression, constipation is very common, and also cognitive impairment. The medication itself can worsen confusion. It's a real balancing act.
So, zooming out a bit to the aging process itself, what are the key fundamentals to keep in mind?
Well, first, aging involves gradual physiological changes, yes, but it's incredibly individualized. It is not the same thing as disease.
That's important.
Very. And functional decline isn't inevitable for everyone. Sure, senses like vision, hearing, maybe taste tend to diminish somewhat naturally over time. But our main role should be promoting person-centered care and actively challenging ageism whenever we see it.
And you mentioned distinguishing conditions. What about overlapping symptoms between, say, depression and neurocognitive disorders?
Ah, yes, that's a common diagnostic puzzle. Both conditions can share symptoms like changes in how someone performs tasks, memory problems, difficulty concentrating, apathy. It can make it really tricky to tease them apart sometimes.
So communication is key. How do we build good rapport with older adults?
It's often about respect and clarity. Address them using their proper titles unless they tell you otherwise. Maintain good eye contact. Speak clearly, at a moderate pace, not too fast, not shouting.
Right.
Show genuine interest in what they have to say. Practice active listening. Validate their experiences, their feelings, and crucially, allow them enough time to respond. Don't rush them.
Those sound like small things, but they make a huge difference.
Yeah.
And talking about safety again. If physical restraints have to be used with an elderly person, what's the standard of care?
The standard is very clear and very high. Continuous, face-to-face, one-to-one observation by a trained staff member.
Continue.
Absolutely continuous. You're constantly assessing their vital signs, checking circulation, looking at skin integrity under the restraints, making sure they're as comfortable as possible. It's intensive, yes, but it's a non-negotiable safety requirement when restraints are deemed necessary.
Okay. Got it. Let's shift gears again. Psychotic in mood disorders, starting with language. Sometimes speech patterns can be quite revealing, right?
Definitely. Language can be a real window into someone's thought processes, especially when they're disorganized.
So what about word salad? What is that exactly?
Word salad is when someone strings words together, but there's no logical connection between them, no meaningful grammar or syntax holding it together. It might sound something like, Blue runs fast house tomorrow. It just doesn't track.
Right, just words jumbled up.
Exactly. It indicates a really significant level of thought disorder, often seen during severe psychotic episodes.
And managing these conditions, medications like antipsychotics often require careful monitoring.
Extremely careful. Take clozapine, for example. You absolutely must monitor their complete blood count, the CBC values, very closely.
Why is that?
Because of the risk of a granulocytosis. It's a rare but potentially life-threatening side effect where the white blood cell count plummets, leaving them highly vulnerable to infection.
Okay, critical monitoring for clozapine. What about other antipsychotic side effects, especially those affecting movement?
Yeah, those are common, the extrapyramidal symptoms or EPS. An acute dystonic reaction is one that's an involuntary muscle spasm. Maybe their head gets stuck, rotated to one side, or their jaw hangs open, maybe drooling. That's an emergency.
What do you do?
Immediate anticholinergic medication, like diphenhydramine usually. Then there's drug-induced Parkinsonism.
Like Parkinson's disease.
Looks very similar. Tremors, muscle stiffness, maybe slow or impaired speech, a shuffling kind of gait. It happens because the antipsychotic is blocking dopamine receptors. And if someone's on, say, flufenazine and they tell you they feel zombie-like, take that seriously. It's not just them being dramatic. It likely connects directly to these EPS effects, slowed movements, bradykinesia, muscle rigidity, maybe cognitive dulling, just reduced spontaneity. It feels awful for them.
So the big takeaway for antipsychotics?
The big takeaway is, if any client on an antipsychotic develops sudden neurological issues like a high fever, say 101 Fahrenheit, severe muscle rigidity, or signs of autonomic instability like changes in blood pressure or heart rate, they need immediate assessment. It could be something serious like neuroleptic malignant syndrome, NMS.
Okay, immediate assessment for those signs. Now, thinking about treatment strategies, what if someone's on an older first-generation antipsychotic, but they still have those negative symptoms, apathy, lack of motivation, social withdrawal?
Right, the negative symptoms. In that case, you'd often expect the treatment team to consider switching to a second generation or atypical antipsychotic, something like paliperidone, perhaps.
Why the switch?
Because those newer atypical antipsychotics generally have better efficacy when it comes to treating negative symptoms compared to the older ones, which were primarily focused on positive symptoms like hallucinations or delusions.
That makes sense. And speaking of symptoms, can you quickly touch on the phases of schizophrenia, active versus residual?
Sure. The active phase is when the positive symptoms are most prominent. The delusions, hallucinations, disorganized speech, or behavior are really florid. The residual phase comes after an active episode, maybe with treatment. The positive symptoms improve significantly, but the negative symptoms like lack of emotion, decreased motivation, social withdrawal might become more apparent or persistent.
Okay. Let's pivot to mood disorders now. And a really critical situation. Antidepressant-induced mania.
Ah, yes, very important. This happens when someone is initially diagnosed with depression. They get started on an antidepressant, maybe like fluoxetine.
An SSRI.
Right. And then suddenly they start showing classic manic symptoms, talking really fast and pressured, thoughts racing, flight of ideas, boundless energy, maybe risky behavior.
So the antidepressant triggered it.
Exactly. It's a huge red flag. It strongly suggests there might be an underlying bipolar disorder that wasn't initially recognized, and the antidepressant has essentially flipped them into a manic state.
What's the immediate action then?
The immediate action is usually to stop the antidepressant right away and start a mood stabilizer medication. It's a fundamental change in diagnosis and treatment.
Wow, okay. So for clients who are experiencing mania, managing things like sleep must be tough.
Incredibly tough. Their energy levels are so high, their thoughts are racing, sleep often goes out the window. So interventions are crucial. Consistent sleep hygiene is key. Regular bedtimes, wake times.
Even when they don't feel tired.
Especially then. Creating a very calm, quiet, dark environment. Limiting stimulating activities, caffeine, screen time before bed. Maintaining those regular sleep-wake cycles as much as possible really helps regulate their internal clock over time.
What about medications like lithium? There's a risk of toxicity, right?
Yes, definitely. Monitoring for lithium toxicity is absolutely paramount. You need to educate the client and family about the signs.
Well, sure.
Things like persistent nausea or vomiting, bad diarrhea, maybe excessive sweating, tremors getting worse, confusion. If those appear, they need an immediate emergency evaluation. It can become very serious very quickly.
And blood tests are important too.
Crucial. Regular blood tests to check the lithium level. And also keep an eye on their electrolytes, especially sodium. A low sodium level hyponatremia, say below 130, maybe 128 MEQL, is an immediate concern.
Why sodium?
Because the kidneys handle lithium and sodium similarly. If sodium levels drop, the kidneys try to hold on to more sodium, and they end up holding on to more lithium too, which can push the levels into the toxic range.
Okay, that connection is key. What if a client with bipolar disorder says they've stopped their medication because they, quote, like the extra energy they get during mania? How do you respond therapeutically?
That's a common scenario. The most therapeutic initial response isn't to lecture them, but to explore their perspective. Something like, tell me more about what you like about feeling this way. What's that experience like for you?
So, understanding first.
Exactly. Validate their experience, understand their motivation. That opens the door to a non-judgmental conversation about the pros and cons of being off medication, including the potential downsides of mania.
And for someone in acute mania right now, what's a top self-care priority you might help them with?
Helping them actively practice self-soothing skills is often a high priority. Things like simple relaxation techniques, deep breathing, maybe mindfulness exercises, even for brief moments. Anything to help them manage that intense agitation and anxiety in the moment.
Okay, let's dive a bit deeper now into depression and anxiety. How does depression look different in children compared to adults?
That's a really important distinction. While adults might verbalize feelings of sadness or hopelessness, children often express those same feelings differently.
Also,
You might see it come out as irritability, crankiness, or lots of physical complaints, stomach aches, headaches, maybe behavioral problems at school or home, withdrawing from friends or activities they used to enjoy, or a sudden decline in their grades. It's often less direct than adult sadness.
so you need to look beyond just sadness. And for anyone with depression, regardless of age, what's always the highest priority goal?
Safety. Always, always safety. Freedom from harm, specifically suicide prevention, has to be the absolute top priority in care planning.
Makes sense. And when you're assessing depression symptoms and looking for improvement, what are you tracking?
You're looking at the core symptoms. Persistent sadness, yes, but also loss of interest or pleasure in things. Anhedonia, changes in socialization, impaired concentration, changes in sleep or appetite, energy levels.
Like signs of improvement.
Improvement would look like reporting no thoughts of self-harm, maybe appetite returning to normal, eating better, having more energy, showing interest in activities again, starting to socialize more.
What if some things improve but others don't? Like maybe their mood is better but they still can't sleep.
Right. So persistent insomnia, for example, would be a clear sign that that particular symptom isn't improving yet, even if other areas are getting better. It tells you where you still need to focus intervention.
What about postpartum depression care? What does a typical outpatient plan look like?
It's usually multifaceted, often involves antidepressant or maybe anti-anxiety medication carefully chosen to be safe if the mother is breastfeeding.
Okay.
Plus, counseling or therapy is vital. Support groups can be incredibly helpful connecting with other mothers going through similar experiences. And practical support, like strategies to promote sleep, is also really important.
Let's switch to anxiety levels. Can you describe the difference between mild and moderate anxiety?
Sure. Mild anxiety, it's actually not always bad. It can increase your awareness, sharpen your focus, even improve problem solving slightly. Your thinking isn't really impaired.
Okay, almost helpful sometimes.
Almost. But moderate anxiety starts to narrow your perceptual field. You have difficulty concentrating on anything other than the source of the anxiety. Your heart rate increases, maybe some physical tension. You become selectively inattentive to things outside the immediate worry.
So focus narrows, becomes harder to think broadly.
Yeah.
What about non-pharmacological ways to improve sleep when someone has anxiety?
Similar to mania, actually. Consistent sleep hygiene is #1, regular schedule, cool, dark, quiet room. Relaxation techniques before bed are great deep breathing, progressive muscle relaxation, maybe a warm bath. Definitely avoid stimulating activities close to bedtime, intense exercise, stressful conversations, caffeine, and sometimes a light carbohydrate snack before bed can help, but avoid heavy meals.
What if someone is in a full-blown panic state right now? What's the very first thing you should do?
Your immediate first response is to speak to the client in a calm, controlled, reassuring voice. Lower the stimulation around them if possible. Your calm presence can help anchor them.
Okay, stay calm yourself. Good advice. Thinking about medications again, paroxetine, Paxil. Any common side effects to warn patients about?
Yes, weight gain is a fairly common one with paroxetine, often in the range of 5 to 15 pounds, sometimes more. It seems to be linked to increased appetite, maybe specifically carbohydrate cravings for some people. Important to mention that possibility.
Definitely. And for non-pharmacological stress reduction techniques,
Right.
what's meant by concentration as a therapy?
That usually refers to types of meditation or mindfulness practices where the goal is to promote focusing your attention deliberately on a single object, a single thought, or even just your breath. It helps quiet the mental chatter and induce relaxation.
Like mindfulness. Got it. What about medications for adolescent social anxiety?
For adolescents, SSRIs like sertraline, for example, are often considered first-line treatment for social anxiety disorder itself.
Okay.
And sometimes beta blockers like propranolol might be used carefully, usually on an as-needed basis, to help manage the physical symptoms of anxiety like the racing heart, trembling, sweating, especially before a specific stressful event like giving a presentation.
So targeting the physical side. Lastly, on anxiety, when you're evaluating someone for an anxiety disorder, what symptoms are you primarily looking for?
You're focusing on things like excessive worry or fear that's hard to control, physical symptoms like frequent headaches or muscle tension, difficulty concentrating because of the worry, restlessness, or feeling keyed up. You want to distinguish these from symptoms more typical of depression or mania.
Right, making that differential diagnosis. Okay, let's move into what can be some of the most difficult situations, dealing with trauma, crisis, and violence.
Yes, these require specific approaches. If you're at a dangerous scene, maybe an accident or disaster, and you have a client who is confused, disoriented due to the trauma or crisis, your absolute priority is getting them to safety.
Now,
The best intervention is often giving very short, simple, concrete directions. Things like, walk this way, follow me to the ambulance. Clear, direct guidance to move them out of immediate danger.
okay, simple and direct. What about a sexual assault victim who's showing signs of severe anxiety right after the event? What might that look like?
You might see them talking extremely fast, maybe in disjointed phrases, hyperproductive speech. They might be completely unable to concentrate or make even simple decisions. That high level of agitation and disorganization signals severe anxiety.
And the term expressed response in a sexual assault survivor, what does that refer to?
That describes the more overt emotional reactions you might see. Things like crying spells, pacing back and forth, maybe cursing or showing a lot of anger, agitation, even hysteria. It's that outward expression of intense emotional distress.
If you encounter someone, say, in an ER with visible injuries that suggest physical abuse, what's your absolute first action?
First action has to be checking the client's injuries. Assess their severity, determine immediate medical needs. Safety and physical well-being come first.
Always physical safety first. And for a client experiencing domestic violence who says they have no resources, nowhere safe to go, and are afraid, what's the most crucial referral?
For immediate physical safety, the most important referral is to a domestic violence shelter or a safe house that provides a secure place away from the abuser.
And before someone who has experienced domestic abuse is discharged from the ED, what's the priority?
The absolute first priority before they leave is to help them complete a workable safety plan.
What does that involve?
Thinking through practical steps they can take to increase their safety, whether they decide to leave, stay, or are unsure. Who can they call? Where can they go in an emergency? What important documents should they try to take? It's a concrete plan for harm reduction.
That sounds vital. Now, trauma-informed care. How would you apply that when approaching, say, a combative homeless client?
Trauma-informed care fundamentally changes your approach. You'd approach calmly, maintain a safe physical distance, avoid any sudden movements that could feel threatening. Critically, you acknowledge their autonomy, their dignity, speak slowly and clearly, explain why you're there and what you're doing before you do it. Offer choices whenever possible, even small ones. And you avoid restraints unless it's an absolute last resort for imminent safety risks. It's about recognizing they likely have a history of trauma influencing their behavior.
That respect and understanding seem key. Thinking longer term now. What's a realistic goal for a client with PTSD?
A really good, realistic goal by the time of discharge might be that the client will independently practice specific coping strategies for dealing with their triggers. Not necessarily eliminating triggers, but managing their response to them.
Building skills.
Yeah.
And how do you know if counseling has been successful in helping a sexual assault survivor reorganize their life? What's the best indicator?
Probably the best indicator of successful reorganization is the absence or significant reduction of post-traumatic stress disorder symptoms. So no more, or far fewer, flashbacks, nightmares, emotional numbing, hypervigilance. They're able to function without being constantly overwhelmed by the trauma.
That makes sense. When planning care for a domestic abuse survivor, what are some key things to remember about the dynamics?
Several important points. First, it often takes multiple attempts for someone to permanently leave an abusive situation. It's rarely a one-time decision. Substance abuse is very often a co-occurring factor, sometimes for both the survivor and the abuser. Abusers frequently use isolation tactics, cutting the survivor off from friends, family, support systems. And never underestimate the role of economic factors. Financial dependence is a huge barrier to leaving for many people.
Those are really important dynamics. And here's a critical thinking point you raised earlier. Why are children so significantly affected by witnessing domestic violence, even if they aren't hit themselves?
It's a profound impact. Witnessing the violence creates intense fear, insecurity, emotional distress. It disrupts their sense of safety, their attachment figures, models unhealthy relationship patterns. The effects can be deep and long-lasting across all ages.
Something we really need to consider in interventions. Okay, what about signs of physical neglect in a child?
You'd look for things like consistently poor hygiene, wearing clothes that are dirty or inappropriate for the weather, reports of being frequently hungry, untreated medical or dental problems, appearing excessively tired or listless, and maybe developmental delays.
And if you suspect child physical abuse, maybe in an infant, what's your absolute first step, even before interviewing the caregiver?
Your priority action must be to alert your social work staff so they can notify Child Protective Services or follow your facility's protocol for direct reporting. Ensuring the child's immediate safety and fulfilling mandatory reporting laws comes before anything else.
Mandatory reporting first.
Yeah.
Got it. Is intimate partner violence something that happens similarly, regardless of sexual orientation?
Yes, absolutely. Research confirms that intimate partner violence occurs across all sexual orientations, heterosexual, gay, lesbian, bisexual relationships. The patterns of power and control, the cycle of violence, the escalation, they are remarkably similar, and victims face very similar psychological impacts and barriers to leaving, regardless of the genders involved.
That's important to recognize. And sometimes cultural beliefs come into play, like a male partner saying he has a right to discipline his wife.
Right. That assertion might reflect a specific cultural belief system that upholds very distinct, often hierarchical gender roles, where traditional male authority is emphasized, sometimes including the perceived right to discipline. Understanding that cultural context is crucial for intervention, even though the behavior itself is abuse. You have to address the behavior while being sensitive to the underlying beliefs.
Tricky balance.
Yeah.
Okay, let's transition now to personality disorders. Understanding the underlying motivations and patterns here seems really key.
It absolutely is. Each personality disorder has its own core features and therefore different priority goals in treatment.
So for borderline personality disorder, BPD, what's the top priority?
Safety. Hands down, the absolute highest priority goal for BPD is safety, specifically preventing self-mutilation or suicide attempts, as impulsivity and self-harm are common features.
Okay, safety first for BPD. What about dependent personality disorder?
With dependent personality disorder, the core issue is an excessive need to be taken care of, leading to clinging behavior and fear of separation. So the priority goal is fostering independence and helping them develop autonomous decision-making skills.
Building independence. And histrionic personality disorder.
That's characterized by excessive emotionality and pervasive attention-seeking. They often need to be the center of attention, might be overly dramatic, and can display inappropriately seductive or flirtatious behavior to draw focus.
Center of attention.
Okay.
Narcissistic personality disorder.
Narcissism involves a pattern of grandiosity, feeling superior to others, a constant need for admiration, and a striking lack of empathy. They often feel entitled, exploit others, and might assert their superiority by demeaning people around them.
Grandiosity, lack of empathy, and finally, antisocial personality disorder. What are the key symptoms there?
Key symptoms include egocentrism. The world revolves around them, setting goals based purely on personal gratification with little regard for others, an incapacity for mutually satisfying intimate relationships, and often a disregard for rules, laws, financial responsibilities, or special obligations.
That disregard for rules sounds challenging to manage. How do you handle disrespectful behavior from someone with antisocial personality disorder therapeutically?
The key is to remain calm and non-reactive yourself. Don't get drawn into arguments. Set firm, clear, consistent boundaries on the disrespectful behavior itself. Use direct, honest communication, but without being punitive or judgmental. State the limit and the consequence matter-of-factly.
Calm, firm, consistent. What if they try to manipulate you? Like they ask nicely for an exception to a rule, you say no based on policy, and then they get angry.
Classic manipulation tactic. The therapeutic response is, again, consistency. Maintain the boundary firmly. You can acknowledge your disappointment. I understand you're frustrated that I can't make an exception, but then calmly restate the policy or rule factually. Don't engage with the emotional outburst or try to justify the rule excessively. Just state it and hold the line.
Acknowledge feeling, restate boundary. Got it. What about avoidant personality disorder? How might they react to a compliment?
Someone with avoidant personality disorder often has an intense fear of criticism or rejection and deep feelings of inadequacy. So if you give them a compliment, they might actually verbalize pleasure, oh, thank you, but then immediately reject it or dismiss it somehow, oh, this old thing, or you're just being nice. It's that fear overriding the ability to accept positive feedback.
Interesting reaction.
Yeah.
And communicating with someone with paranoid personality disorder who is inherently mistrustful.
That requires a specific approach. First, you have to understand that their mistrust is a core symptom of their illness. Try not to take it personally. Use de-escalation techniques if they become agitated. Avoid direct confrontation, which can escalate paranoia.
Okay.
Developing and sticking to a regular, predictable routine can sometimes help reduce anxiety and suspicion. And setting clear, consistent boundaries is important here too.
And here's a critical thinking point. Why is it inappropriate to just disregard their behavior or avoid caring for them because they're paranoid?
Because their paranoia is part of their illness. Avoiding them or dismissing their concerns, even if unfounded, essentially validates their fear of being mistreated or ignored. Therapeutic care means recognizing the symptom, managing your own reaction, and providing consistent, respectful care despite the mistrust while still maintaining professional boundaries.
That's a really important perspective. What about responding to self-harm, like scratching? What's the most therapeutic initial response?
The most therapeutic initial response is usually to explore the feelings and triggers that occurred before the act. Asking something gentle like, tell me what you were feeling right before you scratched yourself.
Why that question?
Because it helps the client start to make connections between their internal state feelings, thoughts, urges, and the impulsive behavior. Building that insight is the first step towards finding alternative coping strategies. It's non-judgmental exploration.
Exploring the before. Makes
Oh,
sense.
yeah.
And just quickly, is there a specific tool for screening for tardive dyskinesia?
Yes, there is. The Abnormal Involuntary Movement Scale, usually just called the Ames test. It's a standardized 12-item rating scale used specifically to screen for and track the severity of those involuntary movements associated with TD, which can be a side effect of long-term antipsychotic use.
Ames scale. Good to know. Okay, let's wrap up our deep dive by looking at the bigger picture care outside the hospital, in the community.
Right. The context shifts things. For a community mental health nurse, certain skills become even more vital than maybe in an inpatient setting.
Like what?
Like the ability to navigate and coordinate across different service systems. Case management, social work, housing support, substance abuse counseling. Community nurses often work more independently and need to connect clients with a whole network of resources. That cross-system competency is crucial.
Integrating services.
Yeah.
And thinking about successful medication compliance after discharge, what are the key practical factors?
Beyond the client understanding their meds, two things really stand out as priorities. First, establishing a trusting relationship between the client and the nurse or case manager. Trust is huge. And second, ensuring practical access, like reliable transportation to the clinic or pharmacy to actually get the medication. If they can't get there, the best plan falls apart.
So trust and practical access, often overlooked barriers. And in the community setting, how do you identify a priority intervention for a client?
You're looking for issues that pose significant current risk or severely impair functioning. For example, if a client reports daily marijuana use, and it seems to be impairing their judgment or causing safety risks, maybe related to driving or work or interacting with other medications that would likely become a priority for intervention, you'd need to assess the impact thoroughly.
Assessing the real-world impact. And finally, bringing it all together, the recovery model concepts in community mental health. What are those core principles again?
They really emphasize a person-centered and hopeful approach. Core principles include promoting hope, empowerment, enabling choice and self-determination, working collaboratively with the client, respecting diversity, and being culturally responsive. It's all about focusing on individual strength and supporting the person in achieving a meaningful and fulfilling life, as they define it, not just managing symptoms.
Hope, empowerment, choice, collaboration.
Yeah.
Powerful words. So as we wrap up this deep dive, what does this all mean for you as you're reviewing this material? We've covered a really wide range of topics.
We really have.
From the details of intoxication and withdrawal to neurocognitive changes, mood and psychotic disorders, trauma, personality patterns. It's really about seeing the connections, recognizing the patterns, understanding the why behind the symptoms, not just the what.
Exactly. It's not just about having a list of facts in your head. It's about having a toolkit for critical thinking when you encounter these complex human situations.
Applying compassionate, informed care.
Right. And what's fascinating, I think, is seeing how interconnected all these concepts really are. Substance use impacts mood, trauma impacts personality development, cognitive changes affect safety. A truly holistic, patient-centered approach sees those connections. We really challenge you to think about how these things play out together in real-world scenarios you might encounter.
So here's a final thought to leave you with. Consider how shifting your focus from just what the symptoms are to understanding the why behind those symptoms and behaviors. How does that fundamentally transform your ability to genuinely help someone? How does that shift in perspective empower you, whether you're a practitioner or just an informed individual trying to understand? We really hope you'll continue your own deep dives, stay curious, and keep seeking that deeper understanding.